Delirium with Dementia for the Nurse Practitioner. Welcome to the education module, Delirium with Dementia. The purpose of this module is to discuss the neuropsychiatric syndrome of delirium superimposed on dementia. Neurocognitive disorders in delirium and dementia are cognitive impairments that have not been present since birth or early life and are a decline from baseline. Delirium and dementia are syndromes. Delirium and dementia are neurocognitive disorders. Delirium is common in persons living with dementia and can be superimposed on dementia. Older adults living with dementia are vulnerable to delirium. The presence of delirium is 15 to 30 to 53% for postoperative hospitalized older adults and 70 to 87% for adults in the intensive care unit. Up to 60% of persons living in nursing homes and 83% of persons at end of life experience delirium. Symptoms are different than syndromes. Symptoms of delirium are described as a change in mental status. One of the most distinguishing characteristics of delirium includes sudden onset of symptoms. For persons living with dementia, the symptoms of delirium are the same. Both delirium and dementia involve cognitive changes. A thorough assessment is critical to distinguish between delirium and the progression of disease process. Delirium has three presentations: hyperactive, hypoactive, and mixed delirium. Verbal and physical symptoms are characteristics of hyperactive delirium. Somnolence describes hypoactive delirium. Hypoactive delirium may follow hyperactive delirium and may be overlooked. Hyperactive and hypoactive delirium fluctuate in mixed delirium. Because mental status changes that are different from baseline may be the first symptom of delirium superimposed on dementia, it is important to think broadly. The cause of delirium is multifactorial, and symptoms of delirium can be a domino effect. One symptom intensifies another. Finding the underlying cause is challenging. Dementia itself is undiagnosed in older adults, and baseline mental status is often unclear. Many times, environmental causes are not recognized as contributing factors. Because a routine is calming for persons living with dementia, disruption in routine should be considered. Sometimes environment is unfamiliar or disrupted, and poor sleep is a significant factor. Mobility is an intervention to prevent delirium in older adults, and therefore, immobility is a contributing cause of delirium. Iatrogenic exposure, such as anesthesia and restraints, are important considerations. Infection as a result of catheters contribute to delirium. Medications are also a priority concern. New medications and even routine medications is a common underlying cause for delirium superimposed on dementia. The patient's medical history can provide some clues for delirium, such as respiratory, cardiac, and endocrine conditions are among common causes for delirium. Organ failure, shock, and sepsis are more serious causes of delirium. Substance use and alcohol may be overlooked. Urinary and fecal incontinence are other causes of delirium. There are several assessment tools for delirium, such as the confusion assessment method and the ICU confusion assessment method. The screening tools each have a focus. For example, the key features of the confusion assessment method include the altered level of consciousness, acute onset and fluctuating course of delirium, disorganized thinking, and inattention. Because older adults living with dementia are unable to express symptoms, the Delirium Superimposed on Dementia algorithm is a tool that can be used across settings in the hospital, nursing home, assisted living, at home, or emergency department. The Delirium Superimposed on Dementia algorithm has its own focus. Clinicians need to assess for baseline cognitive and physical functioning. It is critical to assess and identify delirium in the early stages. Assessment of risk factors is very important. The Delirium Superimposed on Dementia algorithm specifically recommends assessment for medications, fecal impaction. The Delirium Superimposed on Dementia algorithm specifically recommends assessment for medications, fecal impaction, urinary retention, infection, hypoxia, dehydration, hypo or hyperglycemia, pain, immobility, and sensory loss. Prevention of injury is also essential, such as placing a person with delirium superimposed on dementia into a room closer to the nurse's station, using motor sensor alarms, removing or camouflaging tubes, and using a sitter. Follow-up assessment includes continuous assessment of cognition, monitoring hydration and nutrition, and educating caregivers to detect signs and symptoms of recurring delirium for as long as 2 weeks to 6 months. The Delirium Superimposed on Dementia algorithm can be found on the Hartford Institute of Gerontological Nursing website. Dehydration is both a predisposing and precipitating factor for delirium. Dehydration generally is a predictor of impaired cognitive status. Sensory deficits are important factors for delirium. Routine screenings, such as interventions by healthcare professionals to implement optimal management of sensory impairment, are hence prevention and the management of patients with dementia superimposed. Routine screening and specific interventions by healthcare professionals to implement optimal management of sensory impairments are preventative and included in the management of patients with delirium superimposed on dementia. Some of the things nurse practitioners should be concerned about are on the screen. According to the Diagnostic and Statistical Manual, there are 5 diagnostic criteria for delirium. Attention and awareness are included in the first criteria. Attention is the reduced ability to focus or shift attention. An example of disturbance in awareness is reduced orientation to the environment. The second criteria is a change from baseline attention and awareness that develops over a short interval of time. The change may occur over hours to days. The third criteria is disturbance in memory, orientation, language, visual spatial ability, or perception. To make a diagnosis of delirium, the disturbance in attention, awareness, and cognition is not attributed to a pre-existing condition. Finally, delirium may be due to multiple etiologies. Complex assessment, treatment, and management is needed to prevent and detect delirium. Early recognition of symptoms of delirium and finding the underlying cause is critical. Treatment of the underlying causes or cause can eradicate delirium. Non-pharmacological interventions are first-line interventions such as managing the environment and early mobility after surgery. Non-pharmacological interventions to treat sleep are very important. The cautious use of pharmacology is important. Benzodiazepines exacerbate delirium and cause cognitive deficits. Melatonin has been found to decrease delirium. Haloperidol, on short-term basis, rather than benzodiazepines, is used when safety is compromised. When there is a persistent delirium, persons living with dementia will experience further cognitive impairment. In summary, dementia is a risk factor for delirium. Symptoms of delirium are atypical in persons living with dementia who may have decreased capacity for verbal expression. Symptoms of delirium are often overlooked. There are many overlapping symptoms of chronic illness and dementia that may overshadow symptoms of delirium. Early detection, treatment, and management of delirium decreases mortality and morbidity and improves quality of life for both persons living with dementia and caregivers. Advanced practice nurses who want to know more about neuropsychiatric symptoms of dementia are encouraged to participate in the Dementia and Neuropsychiatric Symptoms series. Thank you for listening to Delirium with or Superimposed on Dementia module.